Hey there, everyone, and welcome back to Studying with Stephanie. Today, we're going to continue on our connective tissue series, and we're going to discuss tendon. So, what is tendon? Tendon is a dense, regular type of connective tissue. And what this means is that the fibers are oriented in a linear fashion, they go in one direction. It's dense, so it's closely packed and it's organized, it's all bundled into a sheath all together. And as a tendon, it is made up of 70% water and 30% of dry mass. That dry mass includes collagen type 1, which is going to be about 70 to 80% of the dry mass. And then the rest of the 20 to 30% of the dry mass is going to be those proteoglycans, those glycosaminoglycans, as well as those proteins, as well as elastin, collagen type 3, 5, and 7. So we have all the odd numbers of collagen in the tendon there. Tendon provides a viscoelastic type of property. And what this means is it's viscous, so it has this thickness and this gel-like property, but it also is elastic, it can stretch, it can move, so it kind of has properties like a water and a gel. But then again, same thing like a fascia where it can stretch a little bit because it does have that elastin in it. When we talk about tendon functions, we know that tendon connects muscle to bone. And it does that through these changes of structures from the muscle and then the tendon through those collagen fibers. So we have those fascicles and those collagen fibers interweaving together to create that musculotendinous junction. The tendon therefore transfers the forces from the muscle to the bone. And depending on where that tendon is imposed, where it is put into the actual bone, it's going to allow for a different length tension relationship of these joints. So the muscle can produce a different type of force dependent on where it is in the tendon inserts into the bone. So if the tendon is a little bit closer to the joint, it can create more force at that joint versus if that tendon is put in further down the bone and it's away from the joint, it can't impose as much of that force along that joint line. So the tendons also help to create this improved length tension relationship of the muscle to the joint itself. The tendons also store elastic energy. So when you're thinking about walking, when your Achilles tendon gets stretched out as your foot is going into dorsiflexion, Achilles actually stores up the energy from that dorsiflexion and then helps to propel and to push that foot forward as your gastrocnemius soleus complex is firing. So it does store that elastic energy within the tendon itself. So the tendon has a lot of different functions. The last thing that the tendon does is it's going to resist tensile forces because it is a collagenous structure and it has elastin in it. It does a good job of getting stretched out, but the stretch and those tensile forces, its ability to resist the tensile forces, are dependent on the cross section of the tendon, so how thick it is, the length of the tendon, and also just its composition as well. So that's what the tendon will do. It protects against these excessive stresses to resist those tensile forces. So we're going to go a little bit more into tendon properties. The tendon, like cartilage, is avascular and aneural in the tendon tissue proper. So that is more of that mid-substance of the tendon. There's no blood vessels and there's no nerves, okay? But when we look at the proximal 1/3 of the tendon, that musculotendinous junction, that first 1/3 of the tendon, because the muscle has so much blood supply and so many nerves and so many vessels, blood vessels, some of those can go into the actual tendon and provide that first 1/3 of the tendon with some vascular properties, and then also that distal third, so where the bone and the tendon connect as well, that the bone also can provide some of the blood flow, some neural connection to the tendon, but that mid substance of the tendon itself does not have any nerve or blood flow. So this means that there's no acute inflammatory response within the tendon itself. But the epitendon and the endotendon, which surround the tendon itself, those are those sheets that surround and kind of help to bundle up the tendon fibers together, that does get blood supply, that does get nerve sensation. So when we do have an acute injury to a tendon, those can get irritated and provide that inflammatory response and give us that initial pain. So when we're talking about this low vascularity, this low aneural type of tissue, we're talking about slow metabolic turnover and slow healing. All right, so the slow metabolic turnover means that there's not a lot of blood flow coming to the area, meaning there's not a lot of that inflammatory response. So those chemicals can't help to remove those waste products and bring in new healthy tissue as quickly. In fact, tendon has 7.5 times less oxygenation than a muscle does. A skeletal muscle has much more oxygenation due to that blood flow. That blood is carrying that oxygen to the tissue and helping it metabolize so that it can heal faster. The tendon doesn't get that so much. So again, this contributes to the slow healing of the tendon. So tendon injury comes more from an acute sudden trauma. Okay, so if there's a sudden trauma to the area, let's say we have a forceful tensile load that overpowers the strength of the actual tendon, it's going to rupture, and it's going to rupture more so in those acute those acute phases. Those acute traumatic injuries rupture more of that musculotendinous junction because the interweavings of the muscle and the tendon and the different structures of those tissue types, the connection isn't as strong, and that's where we can have that site of failure. As well, tendons get injured from a repetitive overuse. So we know this as those chronic overuse or those repetitive activities that cause the tendon degeneration. And then we can also injure a tendon through a rapid unloading. So if we're carrying a box and we just kind of let it go real quick and that tendon isn't able to eccentrically control that force, that's where we can damage that tendon as well. So all of those things contribute to tendon injury. Again, when we talk about tendon injury, that immediate failure typically occurs at the musculotendinous junction. Those repetitive overuse type of issues occur more in the mid-substance of the tendon. And that's why when someone is developing these tendinopathies, they happen over years and years and years when it's a repetitive issue, and it typically doesn't hurt because that mid-substance of the tendon is aneural and avascular, so it's not going to get that inflammatory response that it would if it was an acute injury. All right, so strains of the tendon and partial failure. So strains are when those fibers are starting to disconnect a little bit or get pulled past their threshold. When that occurs, that typically occurs about 6% of a tensile load. And then once we get into the 8 to 10% of stress and tensile loading to the tendon, that 8 to 10% stress and stretch to the tendon can cause tissue failure. Acute injuries to the tendon does lead to pain, localized or diffuse swelling of the area, and then impaired performance. Now, again, this could be due to the musculotendinous junction being injured and promoting that inflammatory response, or the epitendon and endotendon creating that inflammatory response. As I stated, because the mid-substance is aneural and avascular, the tendon proper itself does not have that inflammatory response. Studies have shown that the supraspinatus, the posterior tib, the Achilles, the biceps, and the patellar tendon all have reduced blood supply. versus some of the other tendons in our body. And if you think of that list that I just named, supraspinatus, Achilles, posterior tib, patellar tendon, and biceps tendon, those are very, very, very typical things you see as a physical therapist, as a tendonitis or a tendinosis injury coming into the clinic. And so this can be indicative. Why? Because there is not a lot of blood supply. So that's why things like massage is not necessarily going to be the thing that's going to help to promote healing of the tendon. Although it is going to help with that pain response, it's not going to initially bring the blood flow to the area, because again, these tendons don't get as much blood flow to them, and they also just don't get exposed to a lot of that oxygenation. So we need to eccentrically load these tendons, and we'll talk about that a little bit later on. Tendinosis is something that you as a physical therapy student or physical therapy assistant student should be familiar with. As we like to say, there is no tendinitis, because again, that tendon proper does not get that inflammatory response. So we have reverted and we have said, okay, instead of calling it a tendinitis, we're going to call it acute tendinopathy. So this is an initial injury that the tendon has some sort of changes to it, or a tendinosis, chronic tendinopathy, and that's going to be when the mid-substance of the tendon is actually starting degenerate and disorganize and disassociate from one another. The fibers separate, and this causes an increased mucoid into that ground substance, so it's creating more of that viscous property versus the elastic property. It's causing hypercellularity, so now there's more cellular processes going on within the tendon, and then the nerve and the vessels can actually ingrow into this tendon, which is going to cause a lot of that pain and things that we don't want, because this is not the proper type of structure that these nerves and these vessels should be imposing into. So that is kind of an abnormal sensation, an abnormal symptom that occurs with the tendinosis itself. So when we go into tendon healing, the tendon, like I said, avascular, aneural, so it has that slow metabolic rate. Because of this, the tendons really, like I said, they don't suffice well to necessarily just a massage. They need to be loaded up. The tenoblasts, which are the builder cells for the tendon, come into the area when there's an injury, and they start to lay down the new collagen. When they are laying down the new collagen, early motion is essential for the tendon itself, because that early motion orients these collagen fibers to lay down in the proper direction. They line up to the lines of stresses, where those forces are being imposed, and the direction of those forces is really what helps to integrate the proper collagen lay down and that proper healing, as we talked about in the connective tissue video itself, in the connective tissue proper. So within the first 3 to 4 weeks of the injury, you can see that these collagen fibers are starting to orient themselves to those lines of stress. So again, that is why early motion is so important. Within 3 to 4 weeks, those collagen fibers, if they are being told where to go and how to line up, they are going to orient themselves to the lines of the stress. After about 20 weeks, when we look at tendon injury, you can see that there's minimal to no difference between the injured and the uninjured side, which is very good. But 20 weeks is a long time. If you think about it, there's 52 weeks in a year. So 20 weeks post-injury, the tendon on the injured side actually looks pretty much the same as the tendon on the uninjured side. Eccentric loading is so essential to these tendons, because eccentric loading loads up that tendon 20% more than a concentric load. So we want to make sure that we're lengthening, because again, tendons resist those tensile forces. They resist the stretch, so they get stronger as they are being controlled through that lengthening. And as well, they're able to store up some of that energy to produce during a rapid and powerful movement. So the tendons need that eccentric loading, because that is part of what they do. They store that energy during that stretch so that they can when the muscles contract, they can kind of create spring for us. All right, and then with the eccentric loading, not only does it load the tendon 20% more, it also, in MRI findings, reduces that signal that's within the MRI. Immobilization is a no-no for the tendons. Immobilization itself decreases the strength, increases the stiffness, reduces the total weight capacity that the tendon can tolerate. So immobilization is essentially going to cause so much detriment because, as we spoke about in the connective tissue proper series, or video I should say, the collagen fibers cross-link, they adhere to each other. So with immobilization, within that first 2 to 10 days, that connective tissue proper and that ground substance starts to cross-link. And we know that with tendon, it is a linear orientation. We do not want cross-links in a tendon. We want nice straight fibers. So immobilization is going to be something that we want to avoid. We want to start with light motion, some motion to the area, and then start to gradually load it into those eccentric type of exercises. So I'm sure you know, as a physical therapist, tendons are one of the biggest structures that we treat. It is essential to know the foundations of the tendon in order to help heal the tendon. Again, we are facilitating the tendon healing, the tendon organization as the collagen is laying down. Because of that low metabolic rate from the low vascularity, the tendons are slow to heal, so they can take up to 20 weeks to start to get more like the uninjured side. We want to know this information because not only does it help us treat the patients, but it helps us educate the patients on why just a massage is not going to be enough for them, why we really need to strengthen into these eccentric loads, and why there are so many different types of treatments for the tendons, because it's not a one size fits all. It is so dependent on how the tendon is structurally, how the length of the tendon is, the cross-sectional size, and what the tendon is meant to do. That's why we treat all of these tendons a little bit differently from one another. We want to make sure that we also address the ADLs and the body mechanics when it comes to overuse issues and injuries with our patients, because if we continue to stress that tendon and we create that friction rub that creates that degeneration, it's only going to lead to that tendinopathy. And then down the line, sometimes that tendinopathy can lead to tendon rupture and tendon failure. And that's when we get those post-op rotator cuff, a woman 40 to 60 years old who said, nothing happened, my shoulder just started hurting and I couldn't really use it anymore, and now they have a rotator cuff tear. Well, that's because over years and years and years that tendon has started to degenerate, and there's one issue that now the tendon, you can't really feel it because it's that mid substance of the tendon, it doesn't have the nerves, and then that point of contention, that tendon finally ruptures, and then they have to go into surgery because they've lost function, they start having pain, and they start having impaired performance. So it's really important that we address the tendons properly, that we educate our patients, and that we know what's going on deeper into those cellular levels of the tendon itself, because we are the ones, like I said, that are helping facilitate the healing. So we want to be able to know what we're talking about and really truly help our patients. So that was tendon for you. I hope that you enjoyed. I hope that this helped you out. If you have any questions, please drop it in the comments below. If you need one-on-one tutoring, or you like this video, go ahead and subscribe. Let me know in the comments. Share this with your friends. If there are any topics you want me to go over in future videos, please let me know. Stay on the lookout for a continued topic discussion into our connective tissue proper series. We're going to be going over ligaments in the next one. Thanks so much for coming to Studying with Stephanie, and have a great day.